Good evening, everyone, and welcome to our inaugural webinar on endoscopy. I am Joel Rosh, and I'm chair of today's program and director of pediatric gastroenterology at the OGIB Children's Hospital. I would like to take a moment to thank the faculty, and that's a real thank you. I want everyone to know that a lot of work went into tonight's program, and I think you're going to learn a lot, and it should be very interactive at the end as well. I'd like to take a moment to introduce our faculty. Our moderator tonight is Dr. Stanley Cohen, who is with the Children's Center for Digestive Health Care in Atlanta and adjunct clinical professor of pediatrics at Emory University. Our CME content reviewer for tonight's program was Anu Chawla, director of the Division of Pediatric GI and Nutrition and professor of pediatrics at Stony Brook on Long Island. For our faculty, Marian Pfefferkorn will be our first speaker tonight. She is Associate Professor of Clinical Pediatrics at the Indiana University School of Medicine and the Fellowship Director for the Pediatric GI program there. Our next speaker will be Dr. Stephen Erdman, who is Director of the Fellowship Training Program and Professor of Clinical Pediatrics at Nationwide Children's Hospital in the Ohio State University College of Medicine in Columbus. Michael Manfredi, who is Associate Director of the Gastrointestinal Procedure Unit at Children's Hospital of Boston, will be our third speaker this evening. I would like to pay special recognition to Dr. Peter Mamula, Chair of the NASPGHAN Endoscopy Committee, who helped develop this program from its onset. Also, a special thank you to the NASPGHAN Foundation for Children's Digestive Health and Nutrition, as well as NASPGHAN, for sponsoring this webinar, and a special thank you to Given Imaging, who provided support through an educational grant for this program. I'd like to also thank Amy Manella of NASPGHAN Foundation for coordinating tonight's webinar, and Rick Weimer for his expertise in helping to develop tonight's slide set. When you accessed the program for tonight, you first received a CME upfront language, including disclosures, which are on the next two slides. As a reminder, you will be able to apply for up to 1.5 hours of CME Credit 1 after participating in this program by clicking on the active CME link, which is at the bottom of your webinar page. It is now my pleasure to turn the program over to Dr. Stanley Cohen, who will provide an overview of indications for capsule endoscopy. Stan?
Thank you, Dr. Rosh. And in particular, I'd like to thank you not only for your kind introduction for all of us, but for the great and gracious way that you've organized and initiated this event with Dr. Mamula and with the lovely and lively Amy Manella. What I would also like to remind everyone is that this program will end no later than 9:15. That will include a question and answer session that we're going to have. If you would be kind enough to write in the questions at the bottom right-hand corner of the screen throughout the program whenever you want, we will have the questions and answers at the end of the program. I would like to tell you, however, that the two best questions and the two best answers, as scored by Dr. Rosh and Dr. Chawla, will face off in a Survivor Challenge or dance-off at DDW this year. I'd also like you to know that you will see images this evening that are still images, basically JPEGs. By the time we get to the archive, which should be by May 1st, hopefully we're going to be able to upload a number of videos. We are also trying to build a library of those images, both JPEGs and videos, so that if you have any that you would like to contribute, you will see the link to do so at the bottom of the page, and you can also email them to me as well at scohen@ccdhc.org in order to make sure that they do arrive and that we have that archive building. With that, I'd like to begin the program and then serve as moderator and hopefully not as a mediator. The program's objectives tonight are to identify the indications and contraindications for capsule endoscopy, to explain the utility of capsule endoscopy in pediatric IBD, polyposis syndromes, and obscure GI bleeding. We also hope to implement the appropriate use of capsule endoscopy in pediatric patients. Slide 8, please. As many of you know, the American Society for Gastrointestinal Endoscopy Technology Status Evaluation Report in 2006 released the indications then for capsule endoscopy. They included obscure GI bleeding, including iron deficiency anemia, suspected Crohn's disease, suspected small intestinal tumors, and surveillance in patients with Polyposis syndromes, and suspected or refractory malabsorptive syndromes, such as celiac disease. The contraindications that were known then were known or suspected obstruction or fistula, and any swallowing disorder unless the capsule was placed. There was also a contraindication for patients who had cardiac assistive devices, so that there wouldn't be any problems with those. There have not been any that have clinically shown up. Slide 9, please. In 2011, the FDA also approved monitoring for the mucosal lesions in Crohn's disease, having in 2009 approved the use in patients over 2 years of age. Prior to that, it was 10 years of age. So now it is approved at over 2 years of age. And there have been instances where it has been used in even younger children. These indications have dictated some of the insurance approvals that you have to go through in order to be able to do a capsule endoscopy. But what's interesting is that if you look at the relative frequency for which we do these procedures, when we've looked at the meta-analyses that have been done, what you can see from this slide is that in the adult population, 66% of the patients are having it because of occult GI bleeding or iron deficiency anemia, whereas that's only about 15% in the general pediatric population. Whereas the indication for either monitoring or suspecting Crohn's disease was 10% in the adult populations, whereas it was 63% in pediatrics. The other indications for abdominal pain and polyps were relatively close. What's interesting as well is that it's age stratified. In the patients who are less than 3, it more mimics a midpoint between those two areas, with the occult GI bleeding dropping to 36%, and Crohn's and indeterminate colitis, as well as looking for more extensive disease extending into the small bowel and ulcerative colitis in 24% of those under 8 years of age. Slide 10, please. The advantage of capsule endoscopy in pediatrics is obvious in terms of the fact that it avoids radiation and usually anesthesia. The time that it's used for anesthesia is when the capsule is placed. That's because swallowing is an issue. We've often been successful in what's called pill phasing with a technique that's actually been written up as stimulus fading, where either small jelly beans or small capsules are used, and then the size of those are built up until it represents a large jelly bean or a large capsule that's equivalent to the size of either the patency capsule or the live capsule. Placement is done, but usually with general anesthesia so that the capsule is launched in the correct place. When that's done, you should avoid biopsies in order to avoid any bleeding if possible, so that it doesn't interfere with your interpretation. Usually the placement is to be down in the duodenum, but a duodenal launch can be difficult in small children using one of the two devices that have now been licensed for capsule placement and approved by the FDA. Slide 11. Several practical pointers for you is that, as you know, you can see a lot of other things in there as well as lesions. Those include food particles, bubbles, fecal material, all of which can impair the visualization. There are some things that you can do to help that. Slow gastric emptying and or small bowel transit can lead to incomplete small bowel imaging in approximately 15 to 20% of the patients. So what you want to do is stop non-steroidal anti-inflammatory agents and iron 2 weeks prior. The problem is, however, that PrEPs have not been well studied in pediatrics and have been variable in adults, as have been any of the prokinetics. At our institution, the Children's Center for Digestive Health Care, our protocol includes approximately 160 milligrams of simethicone when they swallow the capsule or when it's placed. And we then look at the real-time viewer at an hour to see whether it's still in the stomach, and if it is, the patient is given a prokinetic at that time. I hope that answers some of the practical issues for you, and I would now like to turn it over to the delightful and insightful Dr. Marian Pfefferkorn, who will speak about establishing the role of capsule endoscopy in pediatric IBD.
Thank you, Dr. Cohen. I will preface my talk with a statement that there are few studies on the role of capsule endoscopy in pediatric IBD, and that current pediatric practice relies on adult data. Up to 30% of patients with Crohn's disease will have isolated small bowel disease, and the most common indication for capsule endoscopy in pediatrics was investigation of suspected Crohn's. Hence, capsule endoscopy should be performed in children with a high suspicion of Crohn's disease, when conventional endoscopy and small bowel imaging are normal. The most commonly used capsule endoscopy diagnostic criterion for small bowel Crohn's disease is the presence of greater than 3 ulcerations in the absence of NSAID ingestion. This was proposed back in 2004. This criterion has not been prospectively validated yet, however. As with other imaging modalities, a diagnosis of Crohn's should not be based on the appearances on capsule endoscopy alone, but should always be interpreted in the context of the clinical history, physical exam, and laboratory data. The photograph on the right, courtesy of Dr. Cohen, shows small bowel ulcers consistent with Crohn's as seen on capsule endoscopy. Slide 14, please. The diagnosis of ulcerative colitis obviously does not require capsule endoscopy, but capsule endoscopy may be indicated in a patient with UC who has persistent anemia or abdominal symptoms in spite of appropriate therapy. The photo on the right, again courtesy of Dr. Stan Cohen, shows a jejunal ulcer in a 9-year-old male with an initial diagnosis of ulcerative colitis who was refractory to previous therapy. In patients with IBD unspecified or indeterminate colitis, the capsule can be helpful in identifying those with mucosal lesions compatible with Crohn's. Between 17 to 70% of patients with IBD unspecified have been reported to have small bowel lesions compatible with Crohn's on capsule endoscopy. Note that a negative capsule endoscopy does not exclude a future diagnosis of Crohn's. Slide 15, please. Next, I would like to compare the capsule versus radiographic studies. Preliminary studies show that capsule endoscopy may be better at identifying small bowel Crohn's lesions compared to the small bowel follow-through, small bowel enteroclysis, and MR enterography. A meta-analysis in 2005 reported that capsule endoscopy is 13 times more likely to identify small bowel Crohn's compared to the small bowel follow-through, and 5 times more likely compared to the small bowel enteroclysis. Pediatric data in 2007 show that capsule endoscopy detected small bowel abnormalities in 19 children compared to only 5 abnormalities detected by the small bowel follow-through in the same group of patients. Albert et al. In 2005 looked at 25 adult patients suspected to have Crohn's. In their case series, capsule endoscopy had 92% sensitivity and 100% specificity compared with 77% sensitivity and 80% specificity for the MR enterography. Slide 16, please. Capsule endoscopy has a potential role in assessment of mucosal healing after drug therapy, especially because of the growing interest in shifting the therapeutic goal from clinical remission to mucosal healing. Capsule endoscopy may be a useful tool for monitoring Crohn's activity and extent. As Dr. Cohen mentioned, last year the FDA approved the use of capsule endoscopy for monitoring mucosal lesions in Crohn's patients. A capsule endoscopy Crohn's disease activity index has been developed and validated in 2008. I would like to discuss this activity index in the next few slides. Slide 17, please. The capsule endoscopy Crohn's disease activity index involves determining the midpoint of the bowel by measuring the small bowel transit time, then dividing the small bowel into proximal and distal segments. The proximal segment would be the small bowel images captured early or in the first half of the study. The distal segment would be the small bowel images in the second half of the study. Each segment is then rated on the basis of three parameters as shown in this slide. A would be inflammation, B would be extent of disease, and C would be presence of strictures. The inflammation score ranges from 0, meaning no inflammation, to 5, which signifies the presence of large ulcers. The extent subscore ranges from 0, meaning no segment involved, to diffuse involvement, which would be a 3. The stricture score ranges from 0, no stricture, to 3, which would be an obstructing stricture. The segmental score is then calculated by multiplying the inflammation subscore by the disease subscore and adding the stricture subscore. It sounds complicated, but it's really pretty simple. It's A times B plus C. Slide 18, please. The same calculation is done for the distal segment, and the final score is calculated by adding the two segmental scores. Possible scores are between 0 to 36. Note that further studies, though, are needed to correlate this capsule endoscopy score with clinical disease activity. Slide 19, please. Other roles of the capsule in established Crohn's patients include the evaluation of persistent anemia and obscure bleeding. Also, it may be useful in the evaluation of persistent unexplained symptoms such as abdominal pain, especially when other investigations are inconclusive. Subtle small bowel lesions may be missed by radiographic imaging. It should be remembered, however, that in contrast to capsule endoscopy, imaging by CT enterography or MR enterography can assess transmural damage and extraintestinal features or complications such as pelvic abscesses. Hence, they continue to be of value. Lastly, for the assessment of postoperative recurrence of Crohn's, capsule endoscopy should be considered if ileocolonoscopy is contraindicated or unsuccessful, when the anastomotic site is not readily accessible by endoscopy, or if the patient does not wish to undergo more invasive testing. Slide 20. The main limitations to be aware of, specifically in pediatric IBD, are first, capsule retention, and secondly, study non-completion. Moy and Levin in 2007 obtained 46 capsule endoscopy studies in 45 children. 33 of these patients had small bowel follow-through examinations prior to the capsule being performed. 5 of the 45 patients had delayed passage from the stomach, and 4 out of the 45 had delayed passage from the small intestine. All 5 patients with gastric retention had normal small bowel follow-throughs. All 4 with small bowel retention had Crohn's disease. With this in mind, a patency capsule may be more useful than a small bowel follow-through X-ray as a screening tool for checking patency of the small bowel. Excretion of a disintegrated patency capsule would suggest a greater risk of retention. of the capsule endoscopy. As far as incomplete studies, a large study published last month by Dr. Cohen showed that the capsule endoscope did not reach the cecum before the video's end in 65 of 284 patients, including 4 patients whose capsules again remained in the stomach. The remaining 61 patients eventually excreted the capsule. Slide 21, please. To summarize, capsule endoscopy should be performed in patients suspected to have Crohn's disease when endoscopy and radiographic imaging are inconclusive. Diagnostic criteria for small bowel Crohn's are lacking. The commonly used criterion of the presence of greater than 3 small bowel ulcers in the absence of NSAID ingestion needs to be validated. The capsule endoscopy Crohn's disease activity index may be more useful when correlated with the clinical scoring system such as the PCDAI or the Physician Global Assessment. Finally, capsule endoscopy is useful in evaluating the mucosa following initiation of therapy to monitor response or document healing. Thank you.
Thank you very much, Dr. Pfefferkorn. That was excellent and enjoyable. I'd like to now turn it over to the provocative and perceptive Dr. Steve Erdman, who will speak about establishing the role of capsule endoscopy in pediatric polyposis syndromes. Dr. Erdman?
Thank you, Dr. Cohen. I would also like to thank the NASPGHAN Organizing Committee for inviting me to participate in tonight's webinar. And I'd like to also echo Dr. Pfefferkorn's comments regarding the fact that we oftentimes have to base our comments on limited information, personal experience, because we are missing a lot of evidence-based data to really help guide us on what's going on in this area. Before I begin, I'd like to start with slide 23. And we need to sit down and consider very carefully about when we do any test or any procedure. And as we were all taught during training, we understand that any test has to certify or meet certain criteria. Is it going to give us a diagnosis? Will this then influence our change, our management, or more importantly, will we be able to determine a progression in the disease process itself that will change our management? The other factors, of course, that we look at in considering any test is the relative risk to the patient and then the overall cost or expense that we accrue in the performance of that test. If we move on to slide 24, please. As we then look at the pediatric polyposis syndromes, we can kind of take a brief snapshot and look at what capsule endoscopy can offer. But before I do this, I also want to make sure I mention that I'm going to be limiting my comments today to the use of capsule endoscopy in the small intestine. There's a fair amount of work and interest in using capsule elsewhere in the gastrointestinal tract, and regarding the polyp syndromes, I'm not going to be addressing these today. The most common syndrome, of course, that we see in the pediatric population is familial adenomatous polyposis. This is a disease of greatest significance for colon involvement, and yet we know many of these children and young adults will have small adenomas in the small intestinal tract, and the majority of these have minimal clinical significance in the pediatric FAP population. And again, coming back to the question of if we know they're there, why would we need to aggressively look for those? There are other polyp syndromes that I think we need to be thoughtful and careful about. First of all, juvenile polyposis syndrome, which we know can be driven by specific gene mutations, has been recently associated with the development of hemorrhagic hereditary telangiectasia, bleeding. And this, I think, is an important factor when we sit down and consider when do we look for bleeding sites, and we're going to hear about that later in this presentation. Other disorders, such as the P10 hamartoma tumor syndrome, where we have polyps that again can cause hemorrhage, but also have very unpredictable or uncertain behavior. And from a diagnostic standpoint, these could be considered as well. The image that I show on slide 24 here is what polyps typically do. They hemorrhage. And in the Peutz-Jeghers population, this is a very important indicator for capsule endoscopy, not only looking for hemorrhage, but also these lesions, based on their fibrous infrastructure, are highly prone to intussusception. And finding these polyps oftentimes can be very important to preemptively deal with some of these risk factors. All these factors being said, it's very hard to make sweeping comments that would apply. And so in any patient, in any given situation, there may be an indication for capsule endoscopy. So each patient with a polyp syndrome needs to be considered on an individual basis based on what you're attempting to ask or what you're attempting to identify. Can I have slide 25, please? Capsule endoscopy has huge appeal. And as I was getting ready to do this presentation, you can just go on the internet and start looking, and it's loaded with appeal for what goes on. Many people have a wide availability and knowledge of this technology. Most of our families will come in specifically asking for this. Typically, it's for all the wrong indications. They want to know why obesity or why inattention at school is caused by a problem, and they think a capsule endoscopy will help them. There are also, again, as Dr. Cohen mentioned early on, other very important advantages and pluses to capsule endoscopy. It's a non-radiation associated form of technology, and it's been shown, particularly for polyp observation and surveillance, to be far superior to small bowel follow-through, where we really can't delineate large polyps from the surrounding mucosa. Magnetic resonance enterography can be beneficial for large lesions, but it cannot have the sensitivity that capsule endoscopy can show. And so when it comes down to looking for unusual findings in a suspected small intestinal patient with small intestinal disease, looking for those lumps and unusual masses and things in the small bowel, capsule endoscopy is uniquely qualified to do that. And here's an example of someone on that lower image there on slide 25 of a Peutz-Jeghers patient, polyp. Slide 26. Oftentimes, then, we divide the evaluation up into two types. There are those that undergo diagnostic capsule endoscopy, but the real claim to fame for capsule endoscopy is in the surveillance, as a surveillance tool in Peutz-Jeghers syndrome. And many individuals that work with these patients will literally do this on a reconnaissance basis. And so the patient undergoes surveillance, capsule endoscopy, and that helps to identify the location, change, and appearance and size of the polyps that these patients have. Whether the lesion is proximal or distal is critical in moving on to the next issue, which is the tandem application of a surveillance plan with capsule applied with a therapeutic device-assisted enteroscopy. And the picture you can see below is, again, a large Peutz-Jeghers polyp that was first identified by capsule and then was later identified and removed by double balloon enteroscopy. So the two together can be a very efficient and effective way whereby patients with Peutz-Jeghers syndrome can have their small bowel polyp burden identified, studied, monitored, and then ultimately removed and treated. Can I have slide 27, please? Well, like any form of technology, there are always limitations. And we have seen this on occasion where we really have difficulty when we look at these images. And part of the problem, of course, with capsule is the lack of luminal distension, so that the polyp is oftentimes abutted up against the surrounding mucosa. As you can see in the middle image, many times we can clearly delineate the pink or more inflamed appearance or red color of the polyp compared to the surrounding mucosa. But the thing we don't understand from that is what else is involved. The capsule moves through at its own rate. We can't back it up. We can't move back and forth. So there are no second looks with a capsule study. And then I am always challenged, and I'm sure many of the other speakers can also comment on this as well, of trying to interpret the image in light of movement of the capsule. Where the capsule will tumble, it will then move retrograde with retrograde peristalsis in the small intestine, or the event where the capsule does not move within the intestine itself, but the intestine moves. So you get the appearance of looking on the travel marker that the capsule is moving, but in reality it's staying in the same place within the intestinal lumen. Next slide, please, slide 28. The other limitations that apply in looking at polyp conditions is that we really have difficulty with the absence of a size marker for capsule endoscopy. Is this small? Is this big? And then because of the fact that we can't distend the lumen, it's difficult to obtain the differentiation between a sessile or a pedunculated lesion. And then, of course, all we can do is look at the polyp. What does it look like under the microscope? Is this going to have dysplastic features? Is this going to be adenomatous? Is this going to be inflammatory? And then a real limitation, of course, with capsule is the fact that we can often have missed pathology or hidden pathology, particularly larger lesions. And the 4 images on the bottom here are from a young lady with a very rare and unusual syndrome where she's missing an arm off of chromosome 10p, which spans 2 very important polyp genes, BMPR1A and P10. And the image that you see first on the left was the upper duodenal lesion where she has flat, small lesions. And at her very first double balloon enteroscopy, we encountered the next large lesion over and were able to remove this. She subsequently had 2 additional surveillance studies by capsule, and upon removing the scope after the second one, I identified this flat lesion, which you can see the third over, that had been missed on all of her other capsule endoscopies, as well as another balloon endoscopy. And as I rotated the patient on the table, this large fungating polyp flipped away from the wall, which is what you see there in that 4th lesion, or that 4th slide. So the possibility of missing polyps due to all of the movement issues that I discussed earlier is always a possibility with capsule endoscopy. Next slide, please. That'd be slide 29. So if we sit down and we talk about diagnostic indications for capsule, obviously we can use these based on clinical signs and symptoms in the setting of suspected polyp disease. And it's persistent hemorrhage that we suspect as coming from the small intestine by the fact that we've ruled out gastric or colonic sources. And here again, we're going to be talking about bleeding a little bit further into the presentation. And then another possible indication is looking for potential lead points when we have patients with recurrent pain that would suggest possible episodic intussusception that we can't find by any other method. And again, as we know, barium many times lacks the sensitivity and specificity. Next slide, number 30, please. From a surveillance standpoint, capsule endoscopy, as I mentioned earlier, is very helpful in the surveillance of Peutz-Jeghers syndrome. Again, we can estimate polyp size, and we can also use this as a predictor of intussusception risk. And of course, the goal is to remove the polyp prior to intussusception, which oftentimes results in major surgery, necrotic bowel, and bowel resection. The problem, though, that we don't have is that we don't know what surveillance intervals should be applied to each patient. There are patients who grow polyps with this disease quickly. Others will grow them more slowly. And then also the question of surveillance for bleeding and the question of how do we follow up for possible missed lesions is an area that we don't have a good feel for. Regardless, we have to be very mindful of the fact that a capsule endoscopy doesn't help with the question of cancer surveillance, particularly in the pediatric population. First of all, small intestinal cancer in this group is extraordinarily rare, and we can't tell by looking at it grossly. We need to take a tissue sample and look at it on a histologic basis before we can answer that question. Slide 31, please. Finally, not everything we see that looks like a polyp is a polyp. And there are a variety of disorders that can have polyp-like appearing structures, particularly towards the end of capsule studies in the terminal ileum, we'll find nodular lymphoid lesions like those seen here, and then prominent vascular lesions can also appear polyp-like in structure. Other important lesions or disorders that can give polyp appearance in the small intestine would include Cronkite Candida syndrome. I've had intestinal duplications that will give that appearance. And then we must be ever mindful of the other rarer but far more significant disorders of lymphoma and other small bowel cancers. And then finally, in the transplant population, capsule endoscopy can be used to identify post-transplant lymphoproliferative disease, which again can be mass-like or appearance-like in the way that it appears. Slide 32, please. So in summary then, capsule endoscopy in pediatric polyp syndromes has real advantages. We're able to do a survey of the small intestine. It's easy, it's low risk, there's no radiation. However, we need to be mindful of limitations. There's the resolution, the ever-present possibility of missing lesions, and then the lack of histologic assessment. A take-home message that everyone should remember that a non-diagnostic capsule endoscopy does not rule out disease. And therefore, the situation should drive your decision-making, and at times even would warrant a repeat capsule endoscopy, depending on how concerned you are regarding what's going on. But I think everyone should remember that, again, capsule can be an effective screening tool, and it can be used in conjunction with more definitive but more invasive endoscopic techniques for identification as well as removal of small intestinal polyps. Thank you very much.
Thank you very much, Dr. Erdman. That was very enlightening and helpful. I would now like to turn to Dr. Michael Manfredi. But first, I'd like to remind you also to keep your questions coming. There have been very good ones coming in so far, and again, Dr. Roche will score them at the end of the evening, and we'll have a dance-off or survival challenge for the two best questions and the two best answers when we all see each other at the NASPGHAN reception at DDW. Again, Dr. Manfredi is going to speak on the detection of obscure GI bleeding in the pediatric patient. This thoughtful and thorough presentation should be, again, quite wonderful.
Thank you, Dr. Cohen. I also would like to thank the organizers for giving me the opportunity to speak tonight. So we'll be talking about obscure gastrointestinal bleeding. The diagnosis and management of obscure GI bleeding was challenging for the gastroenterologist until the development of capsule endoscopy and balloon enteroscopy. But before we go any further, we must first define what is meant by obscure gastrointestinal bleeding. This is defined as persistent or recurrent GI bleeding without an obvious etiology after negative evaluations by esophageal gastroduodenoscopy, colonoscopy, and a radiologic evaluation of the small bowel. Slide 35, please. Obscure GI bleeding can then be further categorized into obscure overt, which is bleeding that is clinically evident by hematemesis, melena, and/or hematochezia. Obscure overt bleeding can be active and then become inactive at times. The other subcategory is obscure occult bleeding, which is bleeding that manifests itself as iron deficiency anemia and/or positive stool guaiacs. Slide 36, please. When discussing causes for obscure GI bleeding, we must not forget the possibility of an overlooked lesion in the upper GI tract or in the colon. This could especially be the case in the setting of a patient with severe hypovolemia or significant anemia that may cause lesions to become less obvious on upper endoscopy or colonoscopy. Other reasons would include incomplete visibility due to if there were blood clots or if there was a poor bowel prep. Also, in the proper clinical settings, we should also consider rare things such as hemophilia or Hemosuchus pancreaticus. For example, if a patient had a recent liver biopsy or trauma to the liver and presents with bleeding, we would think of potentially hemophilia. In the setting of necrotizing pancreatitis, the differential would include Hemosuchus pancreaticus. Slide 37, please. Although missed lesions in the upper and lower GI tract happen, obscure GI bleeding primarily focuses on visualizing the small intestine. The advent of technologies like capsule endoscopy and double balloon enteroscopy have allowed people to coin a new term for GI bleeding, the mid-GI bleed, which accounts for approximately 5% of all bleeds, and this is defined by bleeding that occurs between the ligament of Treitz and the ileocecal valve. Next slide, please, slide 38. The etiology of mid-GI bleeding is age-dependent. However, since our data, which seems to be the recurrent theme of the evening, comes from our adult GI colleagues, they use the age of 40 as their cutoff. Patients younger than 40 years of age are more likely to have small intestinal tumors as a source of their bleeding, such as lymphoma, carcinoid, or adenocarcinoma, as well as polyps from hereditary polyposis syndromes. The latter is what we would more likely encounter in our pediatric patient population as a source of bleeding. In addition, patients younger than 40 are more likely to have Meckel's diverticulum, a Delafoy lesion, or Crohn's disease as a source of obscure GI bleeding. Patients older than 40 years of age are more prone to obscure bleeding from a vascular lesion, such as an angioectasia, or NSAID-induced small bowel injury. Slide 39, please. The development of wireless capsule endoscopy truly has revolutionized the investigation of the small intestine. It offers a safe and effective tool to investigate the mid-GI bleed. A recent systematic review of the literature looking at 227 articles revealed that obscure GI bleeding is the most common indication for adults to undergo a capsule endoscopy evaluation, comprising 66% of the patients. This, as kind of mentioned earlier by Dr. Cohen, this is in contrast to children, which we'll discuss a little bit later on in my talk. The overall diagnostic yield of capsule endoscopy in detecting a source of obscure GI bleeding in adults is 60.5%. Of these causes, angioectasia is the most common finding at approximately 50%. Capsule endoscopy also has led to an alteration in therapy in 66% of patients with obscure GI bleeding. Another interesting point is the rate of rebleeding in patients with obscure GI bleeding and a negative capsule endoscopy is less than 6%. Slide 40, please. The next slide depicts 4 images from a patient with blue rubber bleb nevus syndrome. This is a rare venous malformation that can affect the skin, soft tissue, and the GI tract. These lesions are discrete blue to purple. They can be berry-like protuberances that can be polypoid in nature and range in size from anywhere from 0.1 centimeters to 5 centimeters in diameter. They can occur anywhere in the GI tract, but most commonly they were reported in the small intestine, which lends themselves perfectly for a capsule endoscopy diagnosis. These patients commonly develop anemia, so patients with blue rubber bleb nevus syndrome would fall usually into the obscure occult subcategory of bleeding. Rarely do these patients present with massive bleeding or hemorrhage. Slide 41, please. This slide depicts examples of angioectasias. Angioectasia can appear as a small red or purple cluster of vessels, as seen on the far left picture. These vessels can also have a spidery or serpiginous appearance, as seen on the 2 right pictures. Angioectasia's lesions are ectatic blood vessels made of thin wall with or without an endothelial lining, and usually an arterial-venous communication will be present as well. Slide 42, please. In this slide, we see small vessel varices. You can appreciate here the bluish purple hue of the vessel protruding to the surface of the small intestine. The diagnosis, even though small bowel varices are rare, the diagnosis should be considered in a person with portal hypertension and an altered abdominal vascular anatomy, such as in someone who has had any previous abdominal surgery or potentially even abdominal trauma. Slide 43, please. The factors listed below have all been shown to increase your yield of a positive capsule finding. And not surprisingly, these all are somewhat point to active clinical bleeding. If you fall into the obscure overt bleeding category, if you do a capsule endoscopy within 2 weeks of a bleeding episode, if a patient upon presentation has a hemoglobin of less than 10 grams per deciliter, if patient has been persistent bleeding for greater than 6 months or has had more than 1 acute episode of bleeding, all these increase your yield of getting a positive capsule endoscopy. Slide 44, please. As I mentioned earlier, capsule endoscopy has completely changed small bowel investigation. Its superiority to older methods of small bowel investigation for GI bleeding is shown below in two separate meta-analyses performed. When comparing capsule endoscopy to push enteroscopy, we see that capsule endoscopy is superior. In one study, 63% versus 28%, and the second study, 87% versus 14.8% in terms of making a diagnosis. Capsule endoscopy is also superior to small bowel radiography for the detection of obscure GI bleeding. In these same meta-analyses, 42% versus 6% and 87% versus 9.9%. Lastly, when comparing capsule endoscopy to double balloon enteroscopy, we see that both have very comparable diagnostic yields, 60% in capsule endoscopy versus 57% in double balloon. Double balloon enteroscopy has the added benefit of doing therapeutics. However, double balloon is also much more invasive. Slide 45, please. The pediatric literature on capsule endoscopy is largely comprised of case series. However, a recent meta-analysis of pediatric capsule endoscopy by our moderator, Dr. Crohn, was able to pool some of this data. We see that for obscure GI bleeding, overall it accounted for 17% of all the indications for capsule endoscopy in children. This is dramatically less than the 60% seen in adults. Interestingly, as Dr. Cohen had mentioned earlier, if you age stratified children, obscure GI bleeding was the most common indication in children aged 1.5 to 8 years of age at about 36%. In looking at this age group, the capsule endoscopy was successful in finding positive findings in 53% of the cases in this age group. If you look overall at the indications for all pediatric age groups in the studies, capsule endoscopy resulted in specific diagnosis in 60% of pediatric patients with obscure GI bleeding, which is comparable to our adult colleagues. Next slide, please. Now, I know I've talked up capsule endoscopy as the greatest thing since sliced bread, but it does have its limitations. First off, you cannot obtain any biopsies or administer any therapy with this modality. It does not provide adequate views of the esophagus, stomach, or the colon, so it should not replace performing an EGD or a colonoscopy. And it certainly should not replace your second look endoscopy or colonoscopy, since you're not going to be able to get good enough visualization of those structures. Most importantly, diagnostic yield may be reduced in patients with poor bowel prep or delayed gastric emptying. Studies have shown that diagnostic yield of a capsule endoscopy is much less if the capsule does not enter the duodenum within 1.5 hours. Slide 47, please. Lastly, I would like to review the AGA algorithm for the management of obscure GI bleeding. First off, we should determine if we're dealing with obscure occult or obscure overt bleeding. The other thing you need to determine is whether or not you feel a second look endoscopy is warranted. This will really depend on how confident you feel your first look was. If you felt like you had a good view of everything, then you can move on to potentially another modality. However, if someone else did the endoscopy or you're not really sure if your clinical suggestion is more for an upper GI bleed, then a second look endoscopy should be performed first. But if you do not want to perform a second look endoscopy or you've already performed one, then you can decide what to do next. So if you have occult GI bleeding, then capsule endoscopy is the next recommended procedure to do. If you have obscure overt bleeding, it really depends on how severe the bleeding is. If a patient is having massive bleeding with clinical instability, then we would move to other modalities such as angiography. However, if the bleeding is much more stable, then capsule endoscopy would be the next approach. If you did move to angiography and that was negative and the patient is more stable, then you can move to capsule endoscopy. After capsule endoscopy, if the exam is positive, then you move to the specific treatment that's indicated, whether this be medical management or you would go then to perform a balloon enteroscopy to give appropriate therapy or move to surgery. If the capsule endoscopy is negative, then you have to decide what you do next. Remember, when I spoke earlier, only less than 6% of patients have rebleeds after a negative first capsule endoscopy. So you really have to decide what's going on and how stable is the patient. So the things you need to know is how the patient is clinically doing at this time. Is there any overt evidence or obscure or occult evidence of GI bleeding? Is this the first episode of bleeding for this patient, or is it the third or fourth episode of bleeding? And these are the things that you need to take into account, whether to do repeat studies, or, and these repeat studies would include probably a medical scan. You can consider, if you were not convinced from your first capsule endoscopy, you certainly can repeat that, or you can consider laparoscopic surgery or intra-op enteroscopy if necessary. So at this point, once you decide what you want to do, you either do no further follow-up and just wait and see, or you do these other specific treatments. Slide 48, please. In summary, the development of capsule endoscopy has revolutionized the investigation of the small intestine. The yield of capsule endoscopy in obscure GI bleeding is about 60% in both adults and children. Obscure overt bleeding has the highest yield of detection, and capsule endoscopy and double balloon enteroscopy have equal detection rates. However, capsule endoscopy would be your first-line approach since it is less invasive. Thank you for your time and attention.
Dr. Manfredi, that was wonderful. Thank you very, very much. And thank you to all the faculty members. We're going to bring all the faculty together for an interactive discussion. We have some excellent questions that have been asked, and we'll proceed to those in just a moment. I would like to remind you, however, that following the discussion, you can apply for the CME by clicking on the active link at the bottom of the page. Additionally, there will be downloadable videos from this course posted with the archived version. The link will be sent out by May the 1st. There's also a bibliography at the bottom of the screen as well, since a number of different articles have been quoted throughout this. And again, we are trying to expand our endoscopy library. So do send still and video images of interesting lesions to Dr. Pilar Mamela, who is the chairman of the NASPGHAN Endoscopy Committee and was very involved in this program as well. His email address is below, and you can also send them to me at scohen@ccdhc.org. With those announcements for anybody who might have to sign off early out of the way, we will now turn this over to the questions. Dr. Pfefferkorn, you mentioned earlier about the fact that the patency capsule seems to be the best way of minimizing risk for capsule retention, but the question has come up from Dr. Kunde and others about how to use patency capsule. How many hours or days after the patency capsule can you do the actual capsule, and are there any other indications to do so?
Let's see, based on, and I'm going to quote your paper from 2011, when you had 18 patients swallow the patency capsule, the majority of them, 15 of them, were able to pass an intact capsule within a mean of 40 hours. So really pretty soon after passing the patency capsule, these patients had successful capsule endoscopies thereafter.
And how soon should you pass or proceed on with the actual capsule after that?
I guess pretty soon after.
Okay. Actually, let me go back to the quoting of the paper that we published, and that is that patency capsule that was used there had a 40-hour timing window. It's now a 30-hour timing window. So you should see the capsule pass within 30 hours, or if you suspect it's in the rectum, you can go ahead and take an X-ray. There's also a requirement that the actual capsule should be done within approximately a week, so that you're not extending too much time between and the other problems develop. The other question that came up for you in particular, Dr. Pfefferkorn, was the question about strictures. Since the strictures tend to be one of the contraindications to passing the capsule, why is it part of the scoring system?
Say that again. I'm sorry.
Strictures in Crohn's disease are often considered a contraindication to using the capsule endoscopy. Yet it's part of the scoring system in the system that you quoted. Any comments about that?
First comment would be this was based on adult data. So that's one. Contraindication as far as strictures, yes, obviously if one knows that the patient has a stricture, you would not want to order a capsule endoscopy unless this patient is actually scheduled for elective surgery and you exactly want to identify where the capsule will get lodged at, so it can be a marker for the surgeon eventually. But ordinarily you would not want to do a capsule endoscopy in a patient with a stricture unless you're prepared to deal with the stricture. So either surgically, or if you feel that this is an inflammatory stricture, some studies have quoted that these strictures eventually resolve upon institution of corticosteroid therapy, and then the capsule endoscopy would eventually pass.
Good, thank you. Dr. Erdman, the question has come up from Dr. Kunde. Would you do a small bowel follow-through, an MR enterography, or a patency capsule in polyposis syndromes before considering the video capsule? And have you ever found a polyp obstructing a capsule?
I think it all depends on the clinical situation that you're looking at. Certainly I would not do barium because it just does not have the sensitivity or specificity. In many centers, the raging debate has to do with the size of the polyp, particularly the Puig-Jaeger polyp. And many centers have found that when the polyps abutted against the mucosa, capsule endoscopy cannot detect it. And so if you're looking for large lesions, massive lesions, many institutions will do MR enterography, which then utilizes distension of the lumen prior to obtaining the image. So I think it depends on the clinical situation. I think those would be the two most predominant diagnostic options, either capsule or MR enterography. I have never had a capsule retained by a polyp or had that function as an obstruction. And typically, the polyp is mobile and the capsule is able to move around it. Otherwise, you literally have obstructive symptoms with the flow of food debris and chyme through the intestinal tract as well.
Thank you. Dr. Manfredi, the questions come up that since there's a lack of biopsy specimen as a major drawback of capsule endoscopy, how would you interpret doubtful lesions or questionable lesions?
Well, I mean, the main purpose of doing the capsule endoscopy, at least in my opinion, would be to determine if there is a lesion and the general location of where the lesion is, to allow me to at least know what to go for with either, we use our institution single balloon enteroscopy in order to know kind of approximately what to go for. So I'm really looking forward to say, is there something there to go after, and then kind of how far do I need to go into the bowel to get it? So again, I use the capsule endoscopy really to basically, if you look at the small bowel as kind of this vast area, I'm trying to get a general idea of what's possibly there to look at, and then to go after it with another modality. So that's kind of what I would be looking at.
Thank you. Back to Dr. Pfefferkorn. Dr. Lin asks, should capsule endoscopy replace radiologic imaging for small bowel evaluation in newly diagnosed IBD patients?
In my opinion, it's not quite ready to be the diagnostic imaging for the small bowel. Again, you have to be pretty sure that there's no stricture, so you would have to have some small bowel imaging anyways versus the patency capsule before you do the capsule endoscopy would be the main thing.
Okay. Anybody else have any comments on that? In that case, let me go on to Dr. Erdman. Two questions that are related, one from Dr. Khalil and one from Dr. Leibowitz, basically asking, what are your indications for performing enteroscopy for lesions that are seen on capsule endoscopy, and is there an appropriate size that would tell you that you can be safely removing the polyps by double balloon?
Again, if I were going to repeat the question, it's what are the indications for enteroscopy in that setting? And I would ask, again, depending on what disorder you are thinking of. For familial adenomatous polyposis, I probably would not do or proceed with a lesion there unless the lesion was was suspicious. In other words, a large asymmetric lesion, one that was actively bleeding, or something that raised concern. Unlike other lesions, whereby you'll have patients that will have other issues that are bothersome. And again, specifically, what I'm talking about are actively bleeding lesions, lesions of unknown behavior. So its size is the predominant risk factor for Peutz-Jeghers. It's the big polyp that's going to intussuscept. Other than that, it's a difficult call that again boils down to appearance and based on the disease and what we can anticipate for the behavior of the disease. So if again I had a single bleeding lesion, somebody with FAP, that lesion probably needs to come out just as a way to kind of control their hemorrhage. And that's how I would view that.
Dr. Manfredi, are there landmarks that you use to delineate the location of the capsule in the small intestine, particularly as you look at GI bleeding?
That's a very good question. It's probably the most challenging aspect of capsule endoscopy is determining location, and I would love to get everyone's input into how they go about doing this. The factors that I use in general are time. I kind of look at time spent in the bowel. So again, if this is a 8-hour study versus a 2-hour study, it's sometimes helpful to, and depending on where the lesion is, I try to use time to help divide what percentage of the bowel it potentially will be in. Again, sometimes you can determine looking at the bowel itself. Again, you can sometimes determine, ileum if you start seeing some lymphoid nodularity, or different bile tints. Sometimes it can tip you off that you're closer to the ileum, and again, also the monitoring on the belt. So depending on what system you're using, there is a quadrant system, and that's again, it's not 100% accurate in terms of determining the location of the capsule, but it can give you an idea of what quadrant you're in. So I use kind of all those factors to come into play. And at the end of the day, sometimes you're 100% wrong in terms of where you find it, and then you do your balloon enteroscopy and you're searching. So, but I usually take all those into account, and I'd be definitely very curious to see what other people do in the same situation.
What's of note for me is that I have been surprised at times to see the ampulla of Vater at 3 hours into the study, meaning that the capsule had remained within the duodenum for a long period of time without passing and was simply bouncing around, as Dr. Erdman pointed out earlier, and that can be a problem in terms of assessment.
Absolutely, and I would preface that by saying, I kind of, in looking at things, so if you say at 3 hours, then you kind of go from there in terms of where you think you are from the start to the end. So you have to gauge it. So it's not just time, from 1 minute to 7 hours and 59 minutes. It's kind of visible landmarks as well. So, but I agree, it's sometimes challenging.
several questions have come in regarding the youngest patients or the smallest in terms of size and weight for the patients that you've done successfully. I know that for us, the youngest patient to swallow a capsule was a 4.5-year-old that we were able to easily get to swallow a capsule. And our youngest patient was at approximately 2 years of age. Anybody else have any other experience with younger age? And the other question that came up as well for Dr. Erdman is about the youngest patient for balloon enteroscopy.
Well, I'd like to paraphrase, or I'd like to add a question onto that, because the biggest issue we have had problems is not a matter of swallowing the capsule, but getting the capsule through the pylorus. And we've had times where we will end up with 8 hours of stomach images, and that, I think, is another reason that has had us lean, particularly when in doubt, to deliver the capsule endoscopically across the pylorus into the duodenal bulb, just because of the fact that we want to make sure that we get the capsule, get the capsule in a place where we can get an image. I just did one last week where I have 4.5 hours of stomach, and then I have 2.5 hours of small intestine before the battery expires. So that, I guess, is another thing for us that we're concerned about. And that patient had spent those 3 hours in the supine position. They'd swallowed the pill, and then were not, it was a hospitalized patient, so they were bedridden at the time of the study. And here again, it's a matter of patient positioning after the capsule swallowed that I think would have facilitated getting it from the stomach into the small bowel. Getting back to the question of the smallest size of the patient, some instruments come in different sizes, and the Fujinon instrument comes in a slightly smaller version that's a little bit floppier. And I think the literature, there are several individuals in Europe that have done balloon enteroscopy on children as young as 2. It depends on how far down you go, and it depends on what you're after. Our lower weight limit that I have tried has usually been about 17 or 18 kilos, and beyond that, I think we run into a lot greater risk of trauma with the instrument. And we're hoping that someone will ultimately develop a smaller system so that we can go after younger patients. But that's pretty much my weight limitation is usually about 15, 16 kilos.
Dr. Manfredi, do you have any?
No, I agree with that. I think I start thinking about it at around 15 kilos and need a pretty good indication. Again, risk benefit. I think success, is all. Again, depending on how far you need to go, a complete. I think a complete balloon examination is in that age group is very challenging. So if you need to go into the proximal jejunum, I think it's certainly a doable thing in a 15 kilo patient, but certainly there needs to be a really good indication and have other backup plans. For example, if it's a acute GI bleeding, certainly we have our surgical colleagues available to have a backup plan if necessary. But yeah, I agree with Dr. Erdman.
There are several questions that have come in regarding a prep for elective capsule endoscopy. There's really no data within pediatrics. The studies that have been in adults have looked at variable amounts of polyethylene glycol. In our institution, we are actually studying that using approximately 4 capfuls of Miralax the night before, of the polyethylene glycol the night before, and then using a simethicone preparation in the morning. I would caution you to make sure you use a liquid preparation rather than a pill, which will disintegrate and cause flecking through the small bowel as well as the stomach. We will also consider doing a 1-hour look-see using a real-time viewer, and then going on with a prokinetic at that time, usually something like erythromycin. We have a number of wonderful questions that have come in. we want to continue this for just one or two more questions. Let me first turn this to Dr. Pfefferkorn once again, asking with questions coming in, asking about one comment being that MR enterography and capsule endoscopy are complementary in the diagnosis of small bowel Crohn's from Dr. Rios at Nemours. What do you think about that, Dr. Pfefferkorn?
Yes. As I mentioned earlier, MR enterography can outline or give you more detail as far as what's going on in the mucosa, as far as mucosal thickness, outside of the mucosa, as far as complications of abscesses, fistulas. So in that way, they are complementary. The capsule can give you a look from the inside, and MR can give you a look at the mucosa itself and what's outside of the mucosa. So definitely they are complementary.
So basically you agree with that, that the capsule will help with the mucosal view and it seems to help more in the distal, in the proximal view, whereas the MR seems to help more around the terminal ileum and if there's fistulas, correct?
That's correct.
Good, thank you. The question that I'd like to turn to everyone again is, what is the data supporting capsule endoscopy for someone with functional abdominal pain? Any comments about that? That's come in either with functional abdominal pain or irritable bowel. Anybody have a comment? Dr. Erdman?
Well, if I go back to that very first slide, the question is will it give you a diagnosis? Can you find an indication for capsule in that setting? And if I have an individual that has no evidence of GI blood loss through the gastrointestinal tract, no inflammatory markers, I think that it would be a very costly screening tool in that kind of setting. And I think that it boils down to looking for other clues or other indications. We didn't talk about it much so far, but again, briefly, it was the indication of trying to get these studies pre-authorized or pre-approved by insurance. And that has been a significant obstacle in some of these patients that I thought were very straightforward. And so many times when we take someone that has an absence of laboratory findings or absence of other findings and ask for a test like this, we are shut down very quickly. So I think that in someone with functional bowel disorder or functional problems, chronic abdominal pain, irritable bowel syndrome, unless you have more objective findings, I think it's very difficult to get them improved, and I think it diverts people away from other things that may be of better help to them.
Of note, however, is the fact that Dr. Renan Shamir in Israel did a study comparing capsule endoscopy to upper endoscopy and actually found it to be more helpful in undiagnosed abdominal pain, but it was, again, a very small series.
I always like getting you get the best normal pictures in those referrals. So it's always nice to get if you want nice small bowel images of healthy bowel. Usually it's the abdominal pain referrals that usually do that for you for your atlases and stuff. But.
Dr. Kunde asked a question, Dr. Erdman, about the trick of putting a capsule endoscopically into small children in terms of the first turn in the mouth and being concerned about a pharyngeal tear. Any thoughts?
Happened to me just yesterday. This is an issue, and oftentimes I have found that we will end up having to try a smaller instrument, and again, it's a matter of visualization. We will many times try to see if we can get an NG tube down the esophagus first so that you can find out where you are. Typically, the upper sphincter is closed, and I have learned that many times I also have luck doing it the old-fashioned, ancient way of advancing the scope by feel with a finger in the mouth rather than trying to do it visually. And so, yes, that is a concern, and there's a possibility of causing minor traumatic tear and injury to the pharynx getting through that upper sphincter. But it's a matter of just being cautious. And I have found, again, visualization is really tough in that area because it has to be done oftentimes by feel. That's the only clue I can tell people. And that goes back to the way that many of us were taught how to advance a scope in the days of fiber optic endoscopy, where you did it by feel rather than by visualization. And once you had the scope in the esophagus, then you would take the scope and you'd pick it up and you'd look in the eyepiece. And so having that skill, I think, of advancing the scope in the esophagus by feel sometimes can be helpful.
And if I can offer one more trick with that, too, I agree with everything Steve just said, which is very important. And the other thing, as more and more procedures have moved with anesthesia and anesthesiologists in the room, their inclination has to be is counterintuitive to what we need. So their inclination is to extend the neck and let the jaw fall back, which opens the airway but closes the esophagus, and making sure that you flex the neck and thrust the jaw at the time of trying to place the capsule will open the hypopharynx maximally for you to get into the esophagus. Makes the anesthesiologist a little nervous, but it will give you that little bit of advantage. It also really helps when removing foreign bodies. Anytime you're trying to get something in or out of that area, it's a good position to use.
That's a good point, Dr. Rush.
Yeah.
Dr. Manfredi, do you recommend capsule endoscopy in patients who have skin lesions of blue rubber bleb syndrome but no active bleeding?
Well, I think usually it depends on if there's, there has to be a history of, there would need to be a history of some either anemia or some guaiac-positive stools. So there would need to be a little bit of history for GI of some GI bleeding, but as a rule, I think it's a reasonable thing to do. To do a capsule endoscopy to visualize the bowel. But I think you need to know what you're going to be treating. So if you're doing this with the intention to treat, then I think a capsule endoscopy would be indicated. But if the patient has no evidence of anemia or any evidence of blood in their stool, even occult blood, then it's really hard pressed. You're not going to really do anything for it. So I wouldn't necessarily be pushed to do a capsule endoscopy.
Anybody want to comment about celiac disease or intestinal lymphangiectasia?
So I think we're so well trained that celiac disease is a tissue diagnosis, and so as we've talked tonight, the main limitation to capsules not being able to obtain tissue. That being said, as the antibody and the serology gets better in the patients who have high titer, and really we're just confirming, and we so often see gross findings, is it reasonable to do a capsule and confirm grossly? There may be a role for that, and maybe we need to build more evidence for it, but that certainly might be a role.
What about lymphangiectasia? We've had patients where we've been unable to see it on upper endoscopy, and yet it's distal to that, to the ligament of Treitz on capsule. Anybody have similar experience?
I've had a similar experience with that. I think it is helpful, especially if there's some clinical suspicion of lymphangiectasia, and especially with a normal endoscopy. We've had cases where we've been able to see more distal evidence of that. So I agree. I think it would be an indication, at least in my opinion.
Anybody have any experience as well with Meckel's diverticulum, since scans are so unreliable?
Well, the Japanese literature has images of seeing bleeding orifices, and it all depends on what happens when you go by, and it's a matter of being fortuitous. It's a screening tool. And so again, it's a possibility. And if one was looking for a bleeding site, I think a capsule would be a reasonable alternative compared to an empirical balloon enteroscopy, particularly in the distal part of the small intestine. So I think it's an option with what goes on. And again, we have pediatric surgeons that would argue with that, depending on the clinical setting. They would pursue an exploration or laparoscopy as being a definitive way to answer that. So I think it may have a place, and it all depends on whether or not you get lucky and get an image of a bleeding site.
It's been interesting that we've seen Meckel's diverticuli without any actual bleeding, just during a routine capsule study. And the next question, of course, is then what do you do about it? But that's a totally different issue. One last question before we close, and first of all, before we do so, I'd like to very much thank NASPGHAN, the other faculty members, and I'd like to thank the Foundation as well as Given Imaging for sponsoring this. It's been a very instructive evening, and in fact, we're going to cut off that last question, even though we've had some wonderful ones that we haven't gotten to. Again, thank you very, very much. Remember to apply for your CME by clicking on the active link. The bibliography is there. There is a way to send in your images, and you can, in fact, use that same mechanism to send images where you have questions. So if there are studies that you're unclear about, obtain a clip and send it to Dr. Mamela and myself, and we'll see if we can get a group together to review those and have an interactive chat. Again, thank you very, very much, and good evening. I hope you have a pleasant time and hope to see you all at DDW and at the NASPGHAN and World Congresses.